Hello, today this is a class about the evaluation series 5. This is about extremity soft tissue sarcoma. We won't be touching anything about retroperitoneal or any other sarcomas. And extremity swelling, suspicious of sarcoma. How will you evaluate and what is the principle of treatment of a case of extremity soft tissue sarcoma? That is what today's class is all about. As we all know, we start with history. What will be the normal history of a suspicious case of soft tissue sarcoma? Patient will have, what are the histories asked when the patient is coming to you? History of radiation. Radiation is one of the predisposing factors, especially a radiation which is dependent on the dose, up to a certain 2000 to 3000 grade. There is an increasing chance of developing soft tissue sarcoma, and also the duration. After 10 years, the risk increases. And chemical exposure, something like dyes like chloroplast, PVC factory, people working in PVC factories and all. There is an increased risk of developing soft tissue sarcomas. Trauma, is it a risk factor or not? Actually, it is not. Many people will give you a history. The swelling appeared after a history of trauma, an episode of trauma. But that is not true. Patient actually notices the swelling because of the trauma. There is no direct link between trauma and the soft tissue sarcoma. Lymphedema. Lymphedema could be a causative factor. Like we know the Stewart-Reese syndrome, that is in an axillary dissection following carcinoma of breast. The risk is very low. That is, the estimated risk is 0.07% after an axillary node dissection. But still, it's a risk factor. It could be an effect also. Sometimes mass can press upon the lymphatics and produce lymphedema. Next is clinical. So brief history, you need to take something which is contributory to the pathology or positive effect. Next is the clinical features. What are the clinical features? Usually the patient will complain about painless, increasing in size a mass. Painless, progressive mass of the limbs, somewhere in them. Sometimes if it's pressing upon the veins, patient may present with DVT, depending on the presentation. Usually the patient may complain about some compression symptoms because soft tissue sarcomas are expansile growths, not infiltrating growths. It can expand into the tissue planes. It can compress various structures like veins, can produce edema. Sometimes artery can produce reduced vascularity. Or compress the muscles, stretch the muscles, skin, like that. You can get compressive symptoms. Neurovascular, if it's a very big advanced lesion, it can even compress, or it can infiltrate or compress on the nerves, can produce distal neurovascular deficit. The nerve can be palsy. All this could be there. It is very important to note the following points, like the position, where is exactly the position, because it influences the type of management you are going to give the patient. Where is the position? Exactly which all muscles, so if it's in the muscle plane, which all the muscles involved, which plane. Plane is also important. Is it in the muscle plane, intramuscular plane, deep to the muscle plane? Is it infiltrating the nerves, or the arteries, or the periosteum, or even the bone cortex? If it's involved in the skin, all these will influence the treatment. So a clear, very important, very careful clinical examination is necessary about all these features. Distal neurovascular deficit, all these are very important. Okay. Lymph nodes. It's very rare to get lymph node metastasis in soft tissue sarcoma, but there are certain lymph node malignancies which can involve the lymph nodes. That is the epithelioid sarcoma, the pediatric abdominal sarcoma, the synovial sarcoma, angiosarcoma, and all these we can get lymph node metastasis. So the regional lymph nodes to be carefully examined. And also the common sites of metastasis with clinical idea, you should examine. Common sites are the lungs, the bones, the brain, all these are, because we know the soft tissue sarcoma spread by the blood-borne metastasis, not lymphatics basically. So you should carefully examine the lungs, bones and brain. So that will be a clinical examination. Once you examine the patient clinically, you have a suspicion of, usually a malignant a suspicious soft tissue sarcoma will be a swelling which is deep or super whatever, a firm swelling with some of the features. Not necessarily they will have all these features. One of these features, you suspect a soft tissue sarcoma. Let's go to the next level. What will you do to this swelling? The first thing we should do is an imaging. The most useful imaging is an MRI. If it's an extremity swelling, it is the most valuable investigation is MRI because it can differentiate between cystic and solid swelling. It can tell you about the plane of the swelling, infiltration of the nerves, vascular compartments. Also, the presence or absence of the necrosis inside the tumor. This will help in the further evaluation like a true-cut biopsy, because if you take a true-cut from a necrotic area, it may not be a representative area. So, MRI of the limb or extremity swelling is the most commonly done investigation for the imaging. But CT scan is the most preferred investigation if the swelling is retroperitoneal, an abdomen, retroperitoneal, or trunk soft tissue sarcoma. So for the limb, MRI, trunk, and retroperitoneal, we would prefer CT scan. So that's the first investigation. From there, you decide. There are features of swelling, with maybe showing necrosis and expansive soft tissue with all the fleshy marks. You've seen MRI with vascularity and all the stuff. So you again suspect soft tissue sarcoma. What is the next thing? Will you go for FNAC first or not? That's the I've written here FNAC, but FNAC is not preferred in a suspected soft tissue sarcoma because one, it cannot differentiate various histological types. It can only show you malignancy. Okay, so cell because it's only few cells. Second, it cannot give you a clue about the grading of the tumor. Okay? Both these are very important in further planning the treatment. So FNAC has no role in the primary diagnosis of a soft tissue sarcoma, but it has got some role in suppose the swelling is a recurrent swelling or a metastatic nodule. Okay, you only need to see is there any malignant swelling cells there. So FNAC may be useful in such situations, but not in the primary diagnosis. The most commonly done primary biopsy procedure is the core biopsy. That is called true-cut biopsy or core biopsy. A core of tissue is taken. With core of biopsy tissue, we can do all these investigations like histological typing, the IHC, and the grading of the tumor. These are the very important diagnostic modalities. The most preferred investigation of biopsy procedure is core biopsy. If it is not possible, you can go for incisional biopsy. So, in core biopsy and incisional biopsy, you make an incision, small incision, and go into the tissue and take biopsy. In incisional biopsy, you should be careful. The incision should be the longitudinal axis of the limb, so that you can excise the swelling in the previous definitive surgical procedure. And also, you should not dissect too much into the tissue planes. Don't create a bleeding or hematoma. And minimal dissection, take out the biopsy and close without the drain. These are the principles we follow in an incisional biopsy. So, core biopsy, not possible with incisional biopsy. We go for an excisional biopsy. Usually not a preferred method, but people, if the swelling is very small, less than 3 centimeters, there is the books say you can go for an excisional biopsy. The problem is excisional biopsies. You don't know whether it's a malignant swelling, so you will not be bothered about the margins. So you will excise it, maybe you will go through the tumor and all, you may spill the tumor, and further next level treatment, that is why excision will be difficult. So excisional biopsy is not preferred, but small tumors, yes, you can go for an excisional biopsy. Will you go for an ultrasound? Is there any? We totally forgot about the ultrasound. It's a very commonly done investigation. We didn't mention anything about that at all. But you really go for? Yes, it can be having a contributory role to whatever you do MRI, especially when you go for a true-cut biopsy. Ultrasound will be helpful to guide the biopsy. Okay, so ultrasound, though no definitive procedure, in the diagnostic procedure, there is some role for the ultrasound also. Okay, now, next level is staging. What are the staging investigations you do? X-ray chest is a must, or CT chest, which one you prefer? The books say X-ray chest is enough in a very small tumor, less than 5 centimeters, and low-grade pathology. All you need is an X-ray chest to stage the lung. But if it's high-grade and a large tumor, more than 5 centimeters, tumor is large and high-grade on pathology, you have to take an CT chest to evaluate the chest. Abdominal and pelvic CT. Certain malignancies like mixed round cell tumor, liposarcoma, leiomyosarcoma, and epithelioid now. There is more chance of metastasizing into the pelvic nodes and pelvic tissues. So abdominal and pelvic CT is a must in these tumors. Okay. Total spine MRI. It's not necessary in every case, especially in mixed round cell sarcoma. So there is a chance of metastasizing to spine. So you have to take a total spine MRI in such cases. Similarly, brain MRI MRI of the brain is not necessary in every case, but in angiosarcoma, epithelioid sarcoma and all, there's more chance of metastasis to the brain. So in such pathology, you need to get a brain MRI also. Or if there are any symptoms, in any of these sarcomas, there's spine symptom, abdominal symptom, or signs, brain signs and symptoms, definitely you have to take. But otherwise, in such people, whatever I mentioned, these pathologies, you need to take a MRI brain and spine. Okay. Is there any role for PET scan? PET scan has no role in the primary evaluation of a sarcoma, soft tissue sarcoma. Its role is in the evaluation of sarcoma after chemotherapy. If you have, suppose you have done a preoperative chemotherapy, if you want to reassess, yes, there are some roles in the evaluation of the PET scan. Now I will briefly tell you what is the staging. Okay, this is the latest staging. Many books are not giving the staging. Not, I think. So this is AGCC 8th staging. So T1 is less than 5, T2 5 to 10 centimeter, T3 is 10 to 15 centimeter, and T4 lesion is more than 15 centimeters. Okay. N1 and N1 is a node positive, M1 is metastasis positive. Okay. Based on this, it's very important to see the stage grouping. Actually, okay. It's very simple to know. T1, that is small tumor less than 5 centimeter, and any size of the tumor actually. T1, T2 is stage 1 disease. Okay. Any size tumor, early grade. That is G1. Well, I didn't mention about the grade. I think before that I should tell you about the grade. The grading is dependent on 3 factors. One is the differentiation, tumor differentiation, the mitotic count score, and an necropsy score. Okay. Depending on that, there are 3 very close, very well differentiated, moderately differentiated, or undifferentiated. That's one. Mitotic count 0 to 9, 10 to 19, more than 20 mitosis per 10 type of field. And necrosis score 0, no necrosis, less than 50% of the tumor necrosis, more than 15%. So these 3 factors need to be considered. That's why we need a core biopsy. Okay, this grading, these 3 factors are studied on biopsy, and group staging of the grading is like this. The total score is calculated. If it's only 2 or 3, you say it's grade 1. If 4 or 5 grade scores are there, you say grade 2, and more 6, 7 or 8, you say grade 3. That's advanced. Okay. So grading is also very important. So this is how you grade the tumor. And because in final stage grouping, grading has got a very prominent role in soft tissue sarcoma. Okay. Not like in any other tumors. So small, any size tumor with the early stage, that's G1, stage 1, is divided into A. Okay. T1 lesion, advanced grading, G2 or G3, stage 2. Okay. Still advanced, T2, there is a 5 to 10 centimeter tumor, advanced stage is stage 3A, and T3 and T4 tumor with advanced grading is stage 3. Okay. Here, the one peculiarity of soft tissue sarcoma is whether it's a N1 or M1, it is stage 4. Okay, lymph node positive is a metastatic, stage 4. Metastasis also stage 4. So lymph node positive means stage 4. Okay, so this stage group, because I am talking about PGs basically, you need to know. So this is very important here. What you should mention is that the grading is very important. You know how to grade the tumor, and not N1 or M1 is stage 4. Okay, so to summarize the entire staging, it will be like this: any sized tumor and low grade is stage 1. Okay, less than 5 centimeter tumor and high grade is stage 2. More than 5 centimeter high grade are stage 3. Regional node positive or metastasis is stage 4. Okay, so that is it about the staging. So accordingly, you have done the staging and you have done the staging investigations. Okay, now after the pathology, you should be able to subclassify the tumor into various types. How you subclassify? There are various methods like the cytogenetics, IHC, and the FISH, all this. So this is the IHC markers. You should know the common IHC markers in various soft tissue sarcomas. Okay. Cytokeratin A will be positive in synovial sarcoma and epithelial sarcoma. EMA will be positive in synovial sarcoma. S100 protein will be in neural tissues. HMB45 melanocytic. SMA desmin will be muscle, myofibroblastic and all. CD34, CD31 will be vascular tissue. Vimentin in mesenchymal tissues. And CD117, CD34, which we didn't mention here because it's a positive in GIST. Okay. So these are our soft tissue sarcomas. Postgraduate should know the commonly done markers and in which all malignancy, which all sarcomas, these markers are likely to be positive, because final subclassification of the soft tissue sarcoma is based on the IHC markers, and the treatment also is varied according to the final type of the soft tissue sarcoma. Okay, so these are the IHC markers you have. So we have taken a history, we have done the clinical examination, we have done the imaging, we have done the biopsy or incisional biopsy, whatever, and then we have staged the disease according to this investigation. We know what is the staging of this disease. According to the biopsy, tissue has already been done IHC, and then we know what type of malignancy it is, what type of soft tissue sarcoma it is we are dealing with. Okay. Now, finally, we have, suppose this patient is now the most important part is the treatment. What is the treatment of this soft tissue sarcoma? Surgery is the treatment of choice. There is no doubt about it. It is not very chemosensitive. Radiation also has a very limited role, limited sensitivity. So, most important role is surgery. Okay. When you talk about surgery, we should know the anatomy, the cross-sectional anatomy of the sarcoma. Okay. This is a tumor around which there is a capsule of the, or maybe broken capsule, and there's a false capsule of the tumor. Accordingly, there are various surgeries described. That is intralesional excision, then there is enucleation, marginal excision, wide local excision, compartmental excision, amputation. But the latest treatment of choice is the margin negative function sparing wide excision. This is the treatment of choice. Okay. Extremity soft tissue sarcoma, the treatment is margin negative function sparing wide excision. That's the treatment. Okay. But there will be indications for some all these which we will touch upon slowly in the subsequent sessions. So based on this is, I don't know whether we can see it properly. So this is the tumor. The red one is a tumor, and around that there is something called a reactive zone around this tumor, and around which will be the normal muscle brain. So if we excise the tumor through the tumor, that is the red area, it's called intralesional excision, which is a suboptimal treatment. Okay, if you go through the tumor, it's intralesional excision. You go through the reaction zone, it's called marginal excision. That again is not a satisfactory operation procedure. If you go away from the marginal zone, reactive zone, through the normal tissue with a wide margin, with a 1 to 2 or 2 centimeter margin, it is called wide excision. That is the treatment you should try to achieve. If you excise the entire compartment, like this, what is shown in the green, it's called compartmental excision, which is also not commonly done these days. This is called compartmental excision. Entire compartment you remove. Okay. So these are the various surgical procedures you do: intralesional, marginal excision, wide excision, compartmental excision, and amputation. Amputation is the removal of force. Okay. So what is the significance of all this? Depending on this, the recurrence rates are very high. Okay. If you go for intralesional excision, almost 60 to 80, even more than that. Some people will have almost 100% recurrence. And marginal excision will have almost 50% recurrence. Even a wide excision, if it's not properly done with the wide, because there will be small tumor deposits outside the margin, whatever you do the wide or outside the wide excision margin, still people say it's 25%. In the radical, like you go for a 5 centimeter clearance, that's what we call radical excision. 5 centimeter or around clearance, we call it, we take for a 4% recurrence. The best treatment will be wide excision, the radiation therapy, which is for a 6 to 10% recurrence. So this is the importance of knowing the tumor, knowing the marginal zone, wide excision and all. If you go wider, wide excision, you get a less chance of recurrence. Okay. Now, this concept of this tumor, and this is called Ennekin's classification. This is based on Ennekin. This is called Ennekin's classification. The tumor, the marginal zone, wide excision. This is called Ennekin's classification. Ennekin's system of tumor excision. There is another system followed. That is called the Kawaguchi staging system. Okay, Kawaguchi has described the natural, two types of barriers is described: the thick barrier and thin barrier. What is thick barrier? This is based on the concept that soft tissue sarcomas are not infiltrating tumor; they are pushing tumor, right? They expansive tumor. They push the barriers. They very rarely infiltrate the barriers. Okay, but in final stage they can infiltrate, but early they will not infiltrate. So the thick barriers are physically strong membranous tissue with a white tendinous cluster. Which are the thick barrier tissues? The iliotibial band, the presacral fascia, and joint capsule. Okay. The thin barriers, there are other barriers called thin barriers, the weaker membranous tissues like the muscle fascia, periosteum of an adult tissue, bone, vessel sheath, neck pinnurea. These are called thin barriers. What is the significance of all these thin barrier and thick barrier? The significance is that if the thick barrier is intact, thick barrier, okay, that is presacral fascia or the joint capsule is intact, it is considered as a 3 centimeter thickness of joint tissue. What does it mean? Suppose this tissue is very close to the iliotibial tract. It is not infiltrated. You don't have to go beyond iliotibial tract and excise the iliotibial tract. You can stop at the iliotibial tract and remove the tumor. And iliotibial tract is considered a 3 centimeter clearance if it is not infiltrated. Okay. Similarly, thin barrier has got a 2 centimeter. Okay. A joint cartilage has got a 5 centimeter. The joint capsule is not cartilage is not infiltrated. You don't have to excise the joint capsule. It is considered as a 5 centimeter margin. But this is very important. A tumor adherent to the barrier and outer surface are involved. That means only the inner surface is the tumor is touching or partly infiltrating the inner surface. Outer surface is intact. You can still excise the tumor, deducting 1 centimeter of clearance. What does it mean? Suppose a thick barrier or iliotibial tract is infiltrating or just touching or adherent to the inner border of the iliotibial tract, but outer border is uninvolved. You can only consider it as only 2 centimeters clearance. Okay, so this is a concept put by a Japanese surgeon called Kawaguchi. Okay, you should know about Kawaguchi's theory. Okay, whatever may be this thing, you excise the tumor. That's the thing. You do adequate margin. What we say, though 5 centimeters is the ideal margin, the purity margin they say, but 1 to 2 centimeters all around. 3-dimensional excision is enough. That's what usually we follow practically 1 to 2 centimeters clearance all around. So that is the thing. If the tumor is removed, if the barrier is not present, you have to remove 5 centimeters. That's 5 centimeters a curative margin, but it's not possible to remove all the tumors with 5 centimeter 3-dimensional excision. So at least 1 to 2 centimeter 3-dimensional excision is whatever is the preferred one. Lymph nodes, as we mentioned, certain tumors where there are lymph node positive, possibly lymph node metastasis, they will be there. The lymph nodes are there enlarged. You have to take an FNAC from the lymph node and confirm if the nodes are positive, you can go for lymph node dissection. Okay, that's one thing. What is the role of amputation? Is there no role at all? Before the era of radiation and chemo, what was 40 to 50% chance of amputation in the limb sarcomas? Now, with a very efficient radiation and chemotherapy, the percentage of amputation in soft tissue sarcoma of the extremities has come down 5% or less. Okay, so it's very rarely we do, but there are indications like a recurrent extremity sarcoma or a limb which is useless, maybe already infiltrated the nerves and all those things, but or we were expecting a useless limb, flail limb, or very extreme, involving the joints, which is going to be a limb is going to be useless. Such rare situations, you can still go for an amputation. Okay, so surgery aims wide excision, which may include excision of the, sometimes suppose involving the vascular tissues, we can excise the vascular tissues and reconstruct it. Suppose involving the nerves, there are certain reports, even if it's involving the peroneal nerve or sciatic nerve, we can excise the nerve and graft it. But that is not a very widely followed system. Generally, if the nerve is gone, infiltrated, flabby, it may be a useless limb, but certain reports are there. Even nerves involvement, infiltration can be grafted. What if it's involving the bone? If it is involving the cortex, there are certain procedures where you can excise the bone and can either put an implant, or you can excise it, you radiate the bone and put the bone back. There are systems like that. If there is no cortical involvement, you can only shave off with the target periosteum. That's enough. Okay, cortex involved, you can give radiation or excision or grafting, or you can give, if not involved, you can excise it with the postoperative radiation. Okay. So that is the surgery, lymph node dissection, and the role of amputation. What is the role of hyperthermic isolated limb perfusion? You may have heard about isolated limb perfusion in case of melanoma, usually followed in melanoma. Suppose the whole limb, multiple lesions are there, recurrent lesions. You cannot do surgical procedure. You can go to hyperthermia. So what the commonly used drugs are tumor necrosis factor alpha or melphalan. Okay, hyperthermic means the drugs will be perfused in the limb with 40 degrees Celsius temperature. With the tourniquet, the femoral vein and artery will be cannulated, and with the oxygenation pump, the limb will be isolatedly perfused and has got some effect on the controlling the disease in a particular limb. Okay, right. Now, this is all about surgical thing. Now, radiation. What is the role of radiation? Radiation has got a role actually mainly in the post-operative system. Okay. Any high-grade tumor which is more than 5 centimeter, there is definitely a role. Okay. There is only situation where it may not be required will be a low-grade tumor which is less than 5 centimeter. So people were not radiated, you can observe it. Or a high-grade tumor with more than 1 centimeter excision margin and less than 5 centimeter. No radiation. In all other situations, high-grade tumor more than 5 centimeter or less than 1 centimeter clearance or infiltrating other structures, you go for post-operative radiation. Some people also give preoperative radiation. If it's a very large tumor infiltrating, not able to excise it, you can give a preoperative radiation, try to reduce it in size and go for radiation. What is the role of chemotherapy? Chemotherapy can be again given in a preoperative and postoperative setup. A tumor which is preoperative indication is a tumor which is more than 10 centimeters in size, large size tumor or infiltrating tumor. You may not be able to excise the whole tumor with margin. You can go for a chemo. I should tell you here, soft tissue sarcomas are now very chemosensitive tumors. Okay, they are not very chemosensitive. Dacarbazine and ifosfamide are the most commonly used drugs, but they are not very chemosensitive. Preoperative chemo can be given, and you can expect the tumor to shrink and make it operable, and can go for an operation. Okay. Certain situation you may need a post-operative chemo also, when the tumor is large, again partial excision or a metastatic tumor, or lymph node metastasis and all. You can also think about a post-operative chemotherapy. Okay. So there is a role for radiation. It will be maybe preoperative setup or post-operative chemotherapy, again preoperative, post-operative. The advantage of preoperative chemo and radiation is that you are radiating or chemotherapy is given to a tissue which is not handled by surgery or radiation before. So the blood vascularity of the tissue will be normal. So maximum effect will be given to the tumor tissues. Okay. So and that's why you can expect the tumor to shrink. That's why radiation, if it's given in the preoperative setup, the radiation total radiation dose will be around 50 gray. But if you give in post-operative, it may be 60 to 70. Because all the tissues are not very taking up the radiation properly. You need good vascularity for radiation tract. Okay. So you need a higher dose of radiation post-operative setup. Next group of treatment is target therapy. A lot of target therapy. There's a tyrosine kinase inhibitors like the imatinib, sunitinib, and all these are so many other new target therapy modalities are coming up in a big way. Okay. So I think that will be the treatment guideline or the outline for the treatment of soft tissue sarcoma. Now I will end up by showing you the final the flow chart. Okay. So the tumor, a history physical examination done, CT, MRI would have done, biopsy done, and it is proven an IHC done. It's proven to be a low-grade tumor. Low-grade tumor is excised, negative margin, no adjuvant therapy. This is what I said. Low-grade, excised properly, no matter. But there is a positive margin, there is a role. If the margin is positive, you may go for a post-operative radiation therapy. Okay. This is a high-grade group. Look at this point. Less than 5 centimeter, more than 1 centimeter clearance, you can no adjuvant therapy. That's the only situation in high grade, that is less than 5 centimeter tumor, more than 1 centimeter clearance, you may opt for a observing disease. In all other situations, more than 5 centimeter, you consider preoperative chemotherapy, more than 10 centimeter also preoperative chemotherapy, and then go for surgery, and then consider a post-operative radiation therapy. This is how you should understand this thing. Less than 5 centimeter, high grade, less than 5 centimeter, more than 1 centimeter clearance, maybe you can consider observation. Any tumor which is more than 5 centimeter, consider preoperative chemotherapy, followed by surgery, and followed by radiation therapy. Okay, radiation therapy will be either external beam radiation, most commonly used will be either brachytherapy or IMRT, intensity modulated radiation therapy, where the tissue alone will be properly radiated. Okay, so this is a outline management of soft tissue sarcoma. I know these are only outlines. Based on this information, you should try to build on. Okay, so you should read about the various individual types of soft tissue sarcomas. There may be slight variation with each individual type of soft tissue sarcoma. The behavior of each sarcoma will be slightly different. These are in principle the broad outline of a management of an extremity soft tissue sarcoma in general. Okay, so if you read on this, you will get a more idea, and based on these basic concepts, you should try to build on. Okay. Hope this session was useful to you, and till we will see you next time. Bye.